Hi, this is Hussein, and today I'm presenting my critical summary of the article, The Influence of SARS-CoV-2 Vaccination on In Vitro Fertilization Outcomes, by Huesler and colleagues, published in 2025. And also I'm going to give a background, explain how the study was designed, walk through the key results, and then share my own evaluation of what the study gets right, where it is limited, and what it means for IVF patients. This study asks a simple but important question. Does COVID-19 vaccination affect IVF success? So COVID-19 infection causes systemic inflammation and can temporarily affect fertility, particularly in men, but most people recover their pre-infection fertility. The possible long-term effects are still being studied. So in late 2020 and 2021, mRNA vaccines were rolled out very quickly. At the same time, there was a big spike in online searches and misinformation about vaccine-related infertility, which created a lot of anxiety for people trying to conceive, especially IVF patients. So clinicians needed real data to answer a very practical question for the patients. Does Pfizer mRNA vaccination actually harm IVF outcomes or not? The Pfizer BNT162b2 vaccine uses messenger RNA inside lipid nanoparticles. After the injection, some cells take up the mRNA and briefly produce the SARS-CoV-2 spike protein. The immune system sees that spike and generates antibodies and T-cell responses. The mRNA and spike expression are short-lived and do not integrate into the genome. So from an immunobiology point of view, that means the immune activation should be transient and targeted. So there is no strong mechanism that predicts chronic damage to ovaries or the uterus. Earlier IVF studies look at things like follicular fluid or very small group of patients. They generally did not show harm, but they were underpowered and often focus on lab markers instead of pregnancy rates. So this study is more informative because it compares actual IVF outcomes in vaccinated and unvaccinated women who are all free of COVID-19 infection, and it focuses on clinically important results like pregnancy. The study population is women aged from 20 to 40 years old undergoing IVF in a hospital-based unit in Israel. The exposed group is women who recently received the Pfizer BNT162b vaccine, and the comparison group is unvaccinated, serology-negative women with no prior COVID-19 infection. So the main objective here is to test whether recent vaccination changes IVF cycle outcomes. And the central research question is, do vaccinated and unvaccinated women have similar IVF pregnancy rates and related cycle parameters, such as oocyte yield, fertilization, and number of embryos transferred? The authors hypothesized that there will be no difference in IVF outcomes between vaccinated and unvaccinated women. The authors used a retrospective case control design. They included all IVF cycles in this unit between January 1st and May 31st, 2021. They limited the analysis to women between 20 to 40 years old. That thing helps reduce the effect of advanced maternal age and makes the sample more comparable. So all the patients were treated with the unit's standard simulation and the laboratory protocols. Because the design is retrospective, they rely on existing clinical records instead of planning the exposures ahead of time. That is so practical, but it gives them less control over co-founding, which we need to keep in mind when we interpret the results. In the vaccinated group, women had received 2 doses of Pfizer BNT162b2 with the last dose between 7 days and 6 months before starting IVF, and not had a known history of COVID-19 infection. The control group was unvaccinated and serology negative for SARS-CoV-2. To have enough controls, the authors included cycles from the same time period in 2021, plus age-matched cycles from January to May in 2018 to 2020. And key outcomes were standard IVF measures, like number of oocytes retrieved, number of mature oocytes, number of fertilized oocytes, number of embryos transferred, and clinical pregnancy based on a positive beta HCG test. So they compared groups using non-parametric tests and then used logistic regression to see whether vaccination predicted pregnancy after adjusting for age. 385 women met the inclusion criteria. 349 were in the control group and 36 in the vaccinated group. Baseline characteristics, including age, body mass index, gravidity, parity, years of infertility, and day 3 FSH, were similar between groups. That supports comparability and reduces obvious baseline bias. When they looked at IVF performance, there were no statistically significant differences between the vaccinated and the unvaccinated women in the numbers of the oocytes retrieved, mature oocytes, fertilized oocytes, or embryos transferred. So ovarian stimulation, follicular development, and fertilization all seem to work similar in both groups. For the main clinical outcome, which is pregnancy rate, the vaccinated group had a rate of 33.3%, which is 12 pregnancies out of 36 women. The control group had a rate of 31.8%, or 111 pregnancies out of 349 women. So the p-value is 0.75, and it tells us that this difference is not statistically significant, as you can see in the graph. In the logistic regression adjusted for the age, the odds ratio for pregnancy in vaccinated women was 1.17 with a 95% confidence interval from 0.56 to 2.44, again showing no significant effect of vaccination. Age had an odds ratio of 0.95 per year with a 95% confidence interval from 0.91 to 0.99, which matches the expected decline in fertility with increasing age. My main concern here is the statistical power. With only 36 vaccinated women, the confidence interval around the odds ratio is wide. The study can rule out a very large harmful effect, but it cannot rule out modest positive or negative effects. So the safest interpretation here is that there is no evidence of harm in this sample, rather than proof that the effect of vaccination is exactly zero. From an immunobiological perspective, this result fit what would we expect. If vaccine-induced immune activation were clearly damaging ovarian follicles or the follicular environment, we would expect fewer oocytes or lower fertilization rates in the vaccinated patients. So the study does not show that. Ovarian response and fertilization appear normal in the vaccinated group. If post-vaccine inflammation or immune changes in the endometrium severely impaired implantation, we would expect a lower pregnancy rate in a vaccinated woman. Instead, the pregnancy rate is very similar and actually slightly higher, although not significantly, in the vaccinated group. Overall, the data support the idea that Pfizer mRNA vaccination causes a transient, targeted immune response that does not chronically damage reproductive tissues or impair early implantation in this time frame. So this matches other studies that have not found negative effects of vaccination on fertility or assisted reproduction outcome, such as the study of Morris, Bentov, and Horan. So the authors conclude that mRNA SARS-CoV-2 vaccination does not influence IVF cycles outcomes. They say there are no short-term effects on the gamete numbers, in viral progression, or pregnancy rate, and they present this as evidence that vaccination is safe for IVF patients. In my opinion, I think their main take-home message is reasonable. In this sample, there is no evidence that vaccination reduces IVF success. However, because the vaccinated group is so small and the confidence intervals are wide, I think the conclusion should be phrased more with caution. I would say that in this cohort, Pfizer mRNA vaccination was not associated with worse IVF outcomes, and that the results are reassuring but not definitive. There are some strengths. The authors excluded COVID infection in both groups using serology, which reduces confounding by the disease itself. They restricted the age range from 20 to 40 years old, which improves comparability. They focus on clinically meaningful outcomes like pregnancy, not just lab markers. Their findings are consistent with the other studies. They also found no major effect on vaccinations on IVF outcomes, such as the findings that Aharon got, Avarham got, and El-Baitawi and Miller got. On the other hand, the limitations are so important. There are only 36 vaccinated patients, which limits the power and leads to wide confidence intervals. The retrospective case control design and the use of historical controls from 2018 to 2020 mean there could be unmeasured differences in patient populations or clinical practice, even though the authors report stable success rates. The regression model adjusts only for age, does not control for BMI because of infertility or male factor, so some co-founding is likely. The study also looks only at short-term outcomes and does not report live birth, miscarriage rates, or long-term ovarian function. Because of these issues, I see the evidence as supportive, but not conclusive. Even with its limitations, this study has important implications. It gives IVF patients and clinicians reassuring evidence that recent Pfizer mRNA vaccination does not reduce IVF success in the short term. So this is valuable for consoling patients who are specifically worried about infertility related to the vaccination. For the field, the result suggests that the transient immune activation produced by mRNA vaccination is compatible with ovarian stimulation, embryo development, and early implantation. Future work must build on this using larger prospective multi-center cohorts with more vaccinated patients, including those receiving booster doses. It will be important to look at live birth, miscarriage, and long-term ovarian reserve, and to measure immune markers in follicular fluid and endometrial tissue, so we can directly connect immunobiology with clinical outcomes. So to wrap up, this study asks whether Pfizer mRNA vaccination changes the IVF outcomes. Using a retrospective case control design in infection-free women aged between 20 to 40 years old, the authors found no evidence of reduced oocyte yield, fertilization, embryo transfer numbers, or even pregnancy rates in vaccinated women compared with unvaccinated controls. And the results are consistent with what we know about how mRNA vaccines work and with other IVF studies, and they also support the message that COVID-19 vaccination is compatible with IVF treatment. At the same time, the small sample size, the retrospective design, and the short follow-up mean that more research is still needed to fully rule out smaller or the long-term effects. Thank you for listening.